Good day. My name is Christian Benedict for Medicine 1, St. Carol's School of Nursing, Lesson 3. In this lesson, we will be looking at injection safety and intravenous therapy. Injection safety looks at all the measures prior to administering an injection or an IV fluid. Intravenous therapy or IV therapy looks at the various types of IV infusions, their effects, their side effects, and generally how they function within the human anatomy. We shall begin with injection safety. First of all, you have to ensure surgical asepsis. As a nurse, you have to ensure that the injection site is surgically prepared prior to administering an IV injection, or an IV infusion. IV injections are intravenous injections. They usually go straight into the vein of the human being. It is therefore necessary that you put in measures to ensure that no bacteria or infection enters through the puncture hole created by the injection. These measures may include cleaning the site with methylated spirit, making sure that you are in the adequate protective gown, ensuring that the environment is clean enough for an IV administration. Other injections may include intramuscular injections and subcutaneous injections. These measures are also implicated when administering such injections. You are supposed to protect the bed linen, and you are supposed to position the patient appropriately prior to administering the injection. Positioning may include lying in the supine position, patient standing bent over, or lying in the prone position, depending on the injection to be administered. As has already been discussed, you are supposed to clean the site with methylated spirit to ensure surgical asepsis. Administer medications whilst observing all patient rules or all patient rights for drug administration. After injection has been administered, ensure that all materials are discarded appropriately to prevent cross-infection or injury during the administration or after administration of medication. Needle pricks. Needle pricks are injuries that may occur as a result of giving an injection or administering an IV infusion. Needle pricks are occupational hazards. When there is a needle injury, what do? First and foremost, put the site where the prick occurred under running water and allow the blood to flow freely. Do not attempt to apply pressure to the site. Attempting to apply pressure may result in early clotting of the area and ensure that the infection remains within the bloodstream. The aim of allowing the site to be under running water continuously is to ensure that all the immediate present or all the surface, the blood at that surface, come out immediately. Inform the nurse in charge or the charge nurse or the nurse supervisor immediately for post-exposure prophylaxis. Post-exposure prophylaxis may depend on the infections that are present in the patient or that are expected to be in the environment. Some patients may have HIV, hepatitis, or any other infection. It is up to the nurse in charge and to you to check the patient's history of infectious disease and to provide the appropriate prophylaxis. Subsequently, document the incidents in the incident book. Choosing an IV site. First and foremost, you are supposed to choose the largest continuous vein distal to the venous junction. That is, you are supposed to choose the largest vein below the arm or below the knee. If you do not understand what below the arm means, you can simply choose the nearest vein, the nearest largest vein, below the elbow. One ought to note that when administering an IV or giving an IV medication, it is important to prick slightly below the level so that at the first instance, when IV access is not attained, you can prick above the level where you first pricked and ensure that IV access is maintained. From inflammation, you note that if you should prick places above a certain level, inflammation takes place at that level. Subsequently, if you are pricking below the level, that prick may be self-defeating. It is therefore necessary to prick from the fingers first, levels from the fingers first, and you move your way up slowly towards the elbow until IV access is attained. In that same manner, in babies or in the aged, sometimes IV access is nearest to impossible on the arms. In such instances, prick levels below the knee to attain IV access. If possible, select the anticubital fossa, that is the place, the hole just opposite to the elbow, the median basilic, the median cephalic veins for shorter term IV because large veins are easily accessible. Choosing sites below the elbow for patient comfort. Metacarpal and dorsal venous networks for the arm are also necessary to be considered when giving IV medication. In the foot, you may look at the plexus of the dorsum, the venous plexus of the dorsum, the dorsal venous arc, or the median marginal vein. As discussed for the reading assignment of lesson 2, you were supposed to read about the IV system and about the circulatory pathway. That's the anatomy of blood vessels in the body. You would have come across all these veins which are present in the foot. The key of that assignment was for you to know which IVs existed at which part of the body, so you would be able to adequately deliver IV infusions where necessary. If you have not done that assignment, I entreat you to do it. IV infusions. Having attained an IV access, you may serve an IV medication directly into the patient's bloodstream. That administration of an IV drug or IV medication directly into the patient's bloodstream is what we term as a bolus. In that sense, you will give the medication without mixing it with any infusion. Note that administering a medication as a bolus may have good effects as well as side effects. Some medications are not supposed to be given as bolus, whereas some can be mixed with infusions and some must compulsorily be mixed with infusions. For a bolus infusion, one may look at medications solely, some medications solely. These medications will most likely be indicated on the prescription. IV fluclose may be given as a bolus or as an infusion. And medication such as potassium chloride may not be given as an IV bolus because of the sodium-potassium pump and because of the low therapeutic index of potassium chloride. In that sense, potassium chloride will be added to an infusion and served so that the patient can receive in bits. Other medications such as B complex may also be added to infusions and served in bits. IV infusions. Under IV infusions, we are going to look mainly at the two types of IV infusions, crystalloids and colloids. IV therapy refers to the treatment of a medical condition using IV infusions. IV infusions is the administration of fluid, either than blood, any fluid, either than blood, to achieve a desired purpose directly into the IV or into the vein. Before setting up an IV infusion or before administering an IV infusion, we are supposed to look at the patient's illness and whether it warrants an IV infusion. Secondly, you are supposed to consider what medication or what treatment the patient is receiving, whether it is contraindicated in the infusion or whether it helps the infusion or whether it is necessitated in the administration of the infusion. Another important step is to check the patient's blood pressure and the pulse before administering any IV infusion whatsoever. Most IV infusions, because given directly into the bloodstream, may implicate on the patient's pulse and on the blood pressure. In that view, it may rapidly increase the pulse or rapidly decrease the heart rate. It may rapidly increase the blood pressure or rapidly decrease the blood pressure and result in medical complications. As such, it is necessary to always check the pulse and the blood pressure, irrespective of the IV infusion. Next, you are supposed to find out the doctor's plan and the purpose of the infusion. And subsequently, you are supposed to assess for the patency of an IV catheter, or what we call a cannula, prior to administering an IV infusion. Rates of IV infusions. Before setting up the IV infusion, you are supposed to have known the desired effect or the desired purpose of the IV infusion. The desired purpose of the IV infusion will dictate the rate at which the IV infusion should be served. Classic examples can be seen at an accident scene that has been transferred to a hospital. In such cases, IV normal saline, as you would come to know, will be administered at a very fast rate. In other cases, say for a hyperglycemic patient who is going into hypoglycemia or who has exhibited a very low or a series of low glucose levels, an IV infusion such as 5% dextrose may be administered at either a fast rate or at a slower pace so that venous stasis will be achieved. It is therefore necessary to always calculate the rate of the IV infusion. Formula for calculating the rate of the IV infusion is to know the total volume of the infusion to be served. Divide it by the time and multiply it by the drop factor of the infusion. Drop factor is usually 15, but may differ from infusion to infusion and is also affected by the cannula size and by the size or the patency of the given set. Other factors to consider before administering IV infusion, just like any medication, may include the patient's weight. Based on the weight, we derive the type of infusion and the amount of infusion to serve. The diet may also dictate the type and the amount of infusion to be served. The type of fluid, the treatment plan, and the side effects may also dictate the type and amount of infusion to be served. Selection of patients for IV fluids. Depending on the condition of the patient, you may administer specific IV medications. A patient with potassium depletion, that is, depletion of potassium content in his blood, may require a D5 half normal saline with 20 milliequivalents per liter of potassium chloride. He may also require other infusions such as Ringer's solution. This is because when potassium content in extracellular fluid is depleted, potassium tends to move out of the cell to ensure a balance between the potassium in the cell and the potassium out of the cell, creating an intracellular deficit in an attempt to ensure balance, as has been stated. This ionic shift causes an imbalance and causes the normal alkalinity of the extracellular cells or extracellular fluid to shift. And this change in alkalinity to acidity is often corrected with Ringer's solution, or as has been stated, D5, 0.5 normal saline with 20 milliequivalents of potassium. In hyperkalemic patients, it occurs as a result of decreased catabolism and excessive sodium intake. 5% dextrose is best suited for this condition to maintain adequate renal flow. For dehydrated patients in less severe conditions, oral routes are often preferred. When fluid loss is too severe or too excessive, the IV route may be considered. For a dehydrated patient, a hypotonic solution or an isotonic solution is often preferred to be administered. In hemorrhagic patients, the goal is to control bleeding and to control shock. Normal saline or other isotonic solutions may be given to replace fluid loss. In hypernatremia, you may expect to give a hypotonic solution such as 0.45 normal saline to correct the fluid imbalance. Types of IV infusions. As we discuss the types of IV infusions, you'll be able to better appreciate in which conditions the IV infusion is served and to know why that IV infusion is often preferred in those conditions. Under the types, you have what we call the crystalloids and you have the plasma expanders or the colloids. From biochemistry and from cell biology, we know that when you have too much solute presence or excessive solute presence within a cell as compared to the outer environment, electrolytes tend to move from the cell to the outer environment to achieve balance. This may be due to diffusion or osmosis. In a hypertonic cell, electrolytes move from within the cell out of the cell to achieve balance. When the amount of electrolyte within a cell is balanced, what you would see is that there will be no true movement of electrolytes from the cell or out of the cell. Neither will there be any true movement of water from the cell out of the cell. And so there is balance, complete balance. And when the cell electrolytes are hypotonic, what you see is that electrolytes will move from the outer environment into the cell to achieve homeostasis. Effect of osmosis on a cell. So when you have too much electrolyte concentration within the cell, what you see is that water will tend to move into the cell to achieve balance, or electrolytes will move out of the cell to achieve balance. When water moves into the cell excessively, you might have a very enlarged cell, which is what we call a turgid cell. And when water moves out of the cell in high amount, you will see that the size of the cell will shrink. And this is what we call a flaccid cell. Flaccidity and turgidity tends to occur depending on the electrolyte concentration within the cell. Crystalloids. Under crystalloids, the main types are hypotonic, hypertonic, and isotonic solutions. Crystalloid is simply an aqueous solution which has very small solutes or electrolytes within them. And as a result, you will see that the molecules tend to move into the cell to achieve homeostasis, or whichever desired effect that the solution was given for. Under crystalloids, you have the hypotonic solutions, the isotonic solutions, and the hypertonic solutions, as previously stated. For hypotonic solution, you would see that we have 0.45 normal saline to be the most common, 0.225 normal saline, and then 0.33% normal saline. Under isotonic solutions, you see we have 0.9 normal saline solution to be the most common. You have a ringgess solution, and you would have lactated ringgess solution. And then under the hypertonic solution, you may have 50-50 solution, or you may have a 5% dextrose. 50-50 solution is simply a 50% dextrose solution, and you will have a 5% dextrose being part of the hypertonic solution. As we go on to explain further, you understand why we have hypertonicity and hypotonicity within the solution. Normal saline. Normal saline contains 154 millimole per liter of sodium and 154 millimole per liter of chloride. You would have a combined osmolarity of 308 millimole per liter. During ward rounds, a smart student or a smart doctor may say normal saline is not really isotonic due to the differences in the osmolarity from the plasma osmolarity, which is 290. However, it is important to note that in terms of function, normal saline tends to function as an isotonic solution, and therefore it is considered isotonic. Normal saline is used to raise the volume of plasma when it is depleted. Normal saline may also be used in resuscitation efforts and to increase extracellular fluid when the body is not producing enough blood or there is decreased extracellular fluid. Note that due to the potassium-sodium pump within the heart, the amount of sodium within the body directly dictates how much the blood pressure or how much the heart should beat, which is the heart rate, and may have consequence on the blood pressure. It is therefore important to note this whenever there is RTA or there is need to resuscitate. In normal saline administration, one has to note that fluid retention is implicated heavily, and circulatory overload as well as acidosis are also implicated, and therefore serve only for the desired purpose, and know that the solution produces all these side effects. Normal saline is not really normal. It is saline, but can produce side effects that may be fatal. Ringer's solution. Oftentimes, Ringer's solution is mistaken with Ringer's lactate solution because of probably unavailability on the hospital unit. But one has to note that Ringer's solution differs from Ringer's lactate solution. This is 0.5 sodium in water added to potassium and calcium. It contains 147 millimole per liter of sodium, 4 millimole per liter of potassium, and 2.5 millimole per liter of calcium. It also contains 150 millimole per liter of chloride. The osmolarity of Ringer's solution is 303 and is also relatively isotonic due to its function within the body. Ringer's solution is used to replace body fluid and to provide additional potassium and calcium in hypokalemia and in hypocalcemia. This is why Ringer's solution is implicated when those two conditions are present. It can also be administered to hypertensive patients who have diabetic ketoacidosis because the lactate is absent, and due to the absence of lactate, ketones are not implicated. Ringer's solution is preferred in hyperglycemic patients with hypertension. 5% dextrose. 5% dextrose is basically used to raise the body's plasma volume and to raise the amount of glucose within the bloodstream. It is used for hypoglycemic patients and to maintain renal tubular function, which facilitates water secretion. Hyperglycemia is contraindicated in 5% dextrose due to the high glucose level in the 5% dextrose. Hypotonic saline, or 0.45% normal saline, contains 77 millimole per liter of sodium and 77 millimole per liter of chloride. This puts the osmolarity of the solution to 159 millimole per liter due to its constituents, and it is therefore considered as a hypotonic solution. This solution is used to raise the plasma volume. A disadvantage may be that it will cause severe edema in intracellular spaces due to rapid movement of solution into vascular space. One also has to note third spacing. Third spacing may be implicated in this. Third spacing is when fluids tend to move from intravascular structure and intracellular structure into other cavities and spaces within the body. In third spacing, one may note swollen abdomens and swollen feet as a result of edema, and even probably swollen cerebral space or cerebral edema in third spacing. And therefore, one has to be cautious when administering 0.45% normal saline. Normal saline may also result in dilution of plasma proteins and electrolytes within the vascular structure. Plasma expanders and colloids. Colloids are homogeneous, non-crystalline substances consisting of large molecules, and therefore they cannot cross the cell barriers and cannot enter the cells. As such, colloids draw fluids from the cells and interstitial spaces into the blood vessel and promote water retention within the blood vessel, thereby increasing the blood or the plasma in circulation. Examples of colloids may include albumin and dextran. Dextran is a synthesized large polymer of glucose in solution, and it is usually served to increase plasma volume rapidly. As was discussed, osmosis and implications are implicated here, and they cause turgidity or flaccidity as well within the cell. It is important to note that in patients with conditions such as sickle cell or cellular congenital abnormalities, dextran may be avoided. There are two varieties of dextran. We have the low molecular weight dextran and the high molecular weight dextran. Low molecular weight dextran can be classically dextran 400, and then high molecular weight dextran can be dextran 70. High molecular weight dextran increases blood viscosity and platelet aggregation, whereas low molecular weight dextran causes a potential osmotic nephrosis and renal tubular shutdown and decreases platelet adhesiveness, leading to bleeding to raw surfaces. Platelet aggregation, one ought to remember from anatomy, that is implicated in bleeding, inflammation, and clot formation. And as such, it is important to note that for patients with clotting problems, dextran may be contraindicated. Dextran, however, may be necessary where blood volume is sharply decreased and we want to sharply increase blood volume without necessarily introducing electrolytes into the patient's body. Dextran may also be served where there is severe edema and severe third spacing, since this will draw fluid from interstitial and extracellular spaces and from body cavities into the blood vasculature and ensure that blood volume is increased. Hemacell. Hemacell is a 500 milliliter mixture of 60% solution containing a polymer of gelatin dried polypeptides. It is composed of 4.5 millimole per liter of sodium, 4.5 millimole per liter of chloride, 5.1 millimole per liter of potassium, and 6.25 millimole per liter of calcium. Hemacell is also used to expand the plasma volume and may also cause rapid high heart rate due to the high amount of potassium within the solution. Advantages include that it has no danger of antigenic effects and can replace up to about 1.5 liters of blood loss. A disadvantage is that it dilutes plasma proteins and decreases colloid osmotic pressure and dilutes clotting factors. As was stated, Hemacell can also cause hyperkalemia or can improve or rapidly increase symptoms of hyperkalemia and can improve heart rate as well. It is therefore necessary to bear in mind these contraindications when administering Hemacell. Finally, for plasma expanders and colloids, we'll be looking at mannitol. Mannitol is a solution in water composed of inert form of the sugar maltose, hence the name mannitol. It helps increase the plasma volume and also reduce edema from third spacing. It can promote osmotic diuresis since fluids from third species all come into the vasculature and are excreted through the kidneys, and can also reduce intracellular swelling. Disadvantage with mannitol is that it is capable of causing circulatory overload in patients with congestive heart failure, pulmonary congestion, and renal dysfunction, since it increases filtration or osmotic pressure in the renal tubules. Patients with renal dysfunctions may suffer more severe complications, pulmonary congestion, and congestive heart failure due to the increased cardiac heart output and increased cardiac volume may also be implicated when mannitol is administered. This is the end of lesson 3. You are expected to read on portal circulation as a reading assignment in preparation for your next lesson. Thank you.